So a ton of new data is coming in different forms. And yes, there's almost too much of it. No clinician wants the data. They don't want to look at your raw sleep score or every EKG. They want the synthesis of what does that mean. So I think what we need to move is from exponential data to insights and actionable information, and then narrow the gap between that insight and something that can be used by the clinician or the patient or the home caregiver in a sense.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Daniel Kraft, a true Renaissance man of health tech. He is a physician-scientist, inventor, and entrepreneur, and he is currently serving as the chair of the XPrize Pandemic Alliance Task Force. Daniel is also the chair of medicine for Singularity University and founder and chair of Exponential Medicine. Daniel has given several TED and TEDMED Talks about the future of health. And on this episode, we discuss specifically the future of pandemics. He believes that COVID has been an accelerant for a new health age, one in which digital tools will help us improve the standard of care at a quicker pace than ever before. Here's our conversation. Welcome, Dan. Thank you for joining me on the podcast today. It's been a long time. I was mentioning to you that the last time we saw each other live was a few years ago at JP Morgan at the fourth season. That's the last time we talked.
Back in the PD pre-pandemic in the old days, but yes,
pre-pandemic.
And it certainly seems like things are accelerating, not just in terms of time, but in terms of technology and healthcare, and the pandemic has certainly been a catalyst and an accelerant at the same time. So good to see you virtually and hopefully in real life.
Yeah. So as you said, the pandemic has been, it's very, for me at least, it's surprising that it happened. I never ever imagined in my life, but it's been a catalyst for the healthcare and the technology. What do you think, how things are going to change, after the post-pandemic with the healthcare? We see a lot more telehealth. People embrace it more. That's one. But what do you think?
Well, I think high level, I guess each of us are not quite old enough to remember, but, Sputnik really sparked the space age. And in some ways, COVID is really, sparking a new health age, meaning, things that were maybe at a 10-year horizon have happened in 10 months in some cases. And I think, we may not end up in a pure post-pandemic world. We're speaking now in, March of 2021, we still have uncertainty about variants. We don't know whether it'll be like the flu and we'll have to get updated vaccines. There may be secondary waves coming from South America or the places that aren't vaccinated or have different. So there's still a lot of uncertainty, but I would say big picture, post-pandemic, the things that are going to change is hopefully, number one, we're going to spend a little more attention to core public health measures, testing, tracing, isolation, identifying epidemics before they're pandemics, realizing we're now in this, much more interconnected world where, you can be anywhere on the planet in, less than 24 hours. And that means so can your next strain of a dangerous bug. So we can hopefully learn a lot of lessons from what went wrong and some things that went right, or certain countries where things like from New Zealand to Taiwan did much better, arguably, than the United States. We can learn that that hopefully the testing modalities, and I've been involved in an XPrize for rapid COVID testing, some of those testing technologies will end up being tests for the common cold or the flu or non-infectious diseases, and we're going to end up blending those into our more continual care. We've obviously seen the world of vaccines accelerate, mRNA, et cetera, very rapid progression. Of course, it wasn't truly a new technology, but the fact that we went from sequencing to a vaccine within a month to clinical trials in 3 months to approvals in 11 is pretty remarkable. And that might hopefully be a silver lining for other ways to accelerate, whether it's repurposed drugs, genetic therapies, new forms of or old forms of elements into the clinic and into patients in faster, smarter ways. So those are a few examples. And finally, I think the post-pandemic world will hopefully be one where we're now more interconnected and collaborative. Just like we're meeting virtually for this podcast, I'm now collaborating and work with folks all around the world that I maybe would never have met or connected to otherwise. And so hopefully some of those cross connections will remain, and the way we learned initially how to treat ICU patients in Wuhan and then in Italy and then New York City, that's improved, let's say, the survival of someone who's in an intensive care unit intubated. We can take some of those accelerant lessons and instead of the usual 17 years from discovery to standard of care, make that more like 7 days or 7 months.
Yeah. And the other thing about the pandemic that I think is also highlighting the challenge of healthcare in this country is the access to care. And for people of color and the underserved population, how do you think that technology and what kind of things that can help that particular area?
Well, I think in general, the pandemic has highlighted the disparities. We've seen terrible disparities in terms of who tends to get sick and have morbidity and mortality. And often that comes from folks who don't have the option of working from home, et cetera. That has some racial elements. Also, the fact that many have had poor underlying health conditions, whether that's related to diabetes or hypertension, that may not have been managed given relatively limited access to care. We're even seeing it play out now, with the rollout of the vaccine. Folks with, even in the same zip code who have some social disparities aren't getting the same access for a variety of reasons. Sometimes it's not just the social determinants of health, the digital determinants of health, whether folks have access to internet or can get online and schedule. We have, pretty horrible examples of all the scattered ways we've tried to set up, vaccine for both testing sites and vaccination elements. I was very lucky and had to scramble to get my parents who live in the Washington, D.C. Beltway area, their first vaccine about a month ago after, lots of challenges. And it was tough for them with pretty socially savvy children, imagine for others. So yes, I think we now are better able to understand and hotspot disparities. And hopefully that again becomes a bit of a catalyst as well for improving health equity. And some of that can be done through new digital platforms, an AI chatbot on your pretty basic smartphone, which, even the poorest on the planet have SMS phones. Soon everyone's going to have the equivalent of a smartphone. Will give folks better access to at least health information or health triage. I think the future of virtual care or in-person care won't start with just showing up in the clinic or on the telehealth visit. You're going to talk to your chatbot. There's several examples from Ada Health out of Europe to Sydney Care that's been launched by Anthem. Where you have a clinical problem, might be abdominal pain, and it asks you a bunch of questions like a good clinician would, but also might know your history. If you've already had your appendix taken out, appendicitis is probably not on your differential diagnosis. But those are going to be your asynchronous elements before you get up-leveled and triage to talk to the doctor or nurse or push to go into the emergency room. We can use those things in smarter ways. And that can, again, can start to democratize access to care, particularly if we use the change and optimize user interfaces so they're not one size fits all and match someone based on their age, their culture, their education, their incentives. We live in the San Francisco Bay Area. We assume, everyone has a Tesla and has an Apple Watch. That's a gross overstatement, but that may not translate to Poughkeepsie or a truck driver in Oklahoma or a clinic in Rwanda. And so I think a lot of these new emergent technologies and solutions need to be really honed and matched to the end user and the caregivers.
It's almost sometimes being in the Bay Area, you're focused on all this new technology and something that's shinier. And I think trying to help people who doesn't have the technology access, how to make sure that they're engaged and they can be healthier. How do you bridge that gap?
Well, there's two elements. There's the consumer side, right? Not everyone can afford a fancy Apple Watch, which is really becoming an FDA cleared device that can do AFib and fall detection, and maybe rumored as of 2022 to have real-time blood pressure and non-invasive blood sugar measurement, which would be a game changer. But as we've seen with many technologies, I had at my Exponential Medicine conference about a year ago the guy who basically invented the cell phone, Marty Cooper, right? And at the beginning, that was only for the super rich to have a cell phone in the 1980s, I guess. Now, of course, they're ubiquitous. You can buy a cheap tablet made in India or China for less than $25, which is better than an iPad was 5 or 6 years ago. So we're going to see these things get cheaper. And arguably, as we show the benefit of, let's say, a wearable or a mobile phone or tablet to preventing rehospitalizations or patient education, it's going to be much cheaper than an X-ray or lab test to, in some cases, make that part of someone's Medicare plan or others. So these tools will be reimbursed or covered because they're going to become integrated into care. it's digital or an app or a wearable or device is not the solution by itself, but when we can go from our world of quantified self. A lot of us are data geeks and track our steps and our sleep and maybe our blood pressure and blood sugar. It's usually siloed on our mobile smart devices. When that starts to connect to our caregiver, I like to call it quantified health, and your digital exhaust or your digital biomarkers can be analyzed and interpreted and made useful for prevention, and optimizing wellness, precision wellness, can be used to pick up disease early, like AFib on your mobile watch, for example, or for therapy, something as common as hypertension or diabetes, using real-time blood sugar numbers or blood pressure numbers to tweak and optimize therapy. All those can deliver much better care at low cost, ideally anytime, anywhere, in a much more equitable way, with better outcomes than we have today in our sick care model based on very intermittent data and a reactive type of system.
And how do you see, our healthcare is very much like a sick care model. Like, you go in because you're sick, you got treated. And prevention is always harder to prove sometimes. It's like, preventing fall. And oftentimes, even, maybe a hospital, when you present them the technology to prevent people from falling, it's hard for them to quantify for something that they want to invest in, something that has not happened or will not happen. And yet it's important. How do you make that something that somebody wants to pay for it?
Yeah, it's a lot sexier in a sense from the old-fashioned medtech model to pay for the hip replacement and the fall and the hospitalization and get a total hip replacement, et cetera. It's harder to pay for prevention and show that, wow, someone's wearing an airbag on their belt and it saved them from a fall, or their wearable device and app can detect someone who's likely to have a fall in the next day or two and intervene. But we are now shifting from fee-for-service to value-based care. And that means the entrepreneurs out there, when they might have a great new solution, need to think about it in the context of who's going to pay for it. How do we prove, in some cases, that this model for prevention, whether it's for mental health or fall detection or taking your meds or all those things that we know can really move the needle, taking a vaccine or getting rapid testing, that we can value them in the right ways. You get what you measure, and it's easy to measure. A hip replacement, an outcome. It's harder to always to pay for and reward for wellness and prevention and the sort of health care side rather than the sick care side. But that, I think, is where the needle is moving. And so there's lots of opportunity to get proactive rather than reactive.
I mean, like the Kaiser model has been focusing a lot of that, right? And I think, but they're a closed system. With the Affordable Care Act, I think now with the Biden administration, I think there's more expansion for that. What do you think the impact would be?
I think the impact is to incentivize the smart use of a lot of these emerging tools. I mean, we've seen a bit of a delay. Just because you can have a smart wearable app or platform doesn't mean they're being integrated and paid for. And in fact, there's a challenge right now, as we've seen an explosion of, let's say, new technologies, particularly in the digital health realm. How does a clinician know what's available? How do you've got a patient with AFib? Well, you might have seen an ad on CNN now for the Cardia, the AliveCore, product, which is a great poster child for a smart, not just medical device, digital health device, but the data sets and the inferences and the actual information that can come from that. I've been looking at that problem. I'm always asked, whether it's from a friend or a consumer, what's the best wearable to track my sleep, or from a clinician. Wow, I didn't know there was an app for managing hypertension or this mental health issue or a cancer patient. So given that there's so much out there, I recently built a new platform called digital.health. That's literally the website, digital.health, to be a bit of a digital health formulary, meaning if you're a clinician and you've got a patient with AFib, depression, hypertension, and anxiety, you might be suggested, wow, you can prescribe them the Headspace app or the Calm app, or you might prescribe them an AliveCore or connected blood pressure cuff or a smart glucometer to integrate with their diabetes management. And ideally for the clinician who doesn't yet want to be overwhelmed with 10 apps and lots of data feeds, you can integrate that smartly into their workflow, because I think that's a big barrier for all these solutions. And, you could be a Kaiser, and Kaiser does have a little bit of an app portfolio for a certain set of measures, from heart disease to, I think, some mental health challenges, which they can prescribe inside the Kaiser system. We're going to see, I think, more of that, the ability to have a digital pharmacopoeia, in a sense, and enable you to find, precision digital health. What's the right solution? It could be an app, a wearable, a platform, a software element that's going to match, your patient or your healthcare system or your provider set in new ways. So I think that's a bit of where all this can sort of head. And that would hopefully mean, better health equity, better health access, and hopefully streamline our sick care system. And for God's sake, we're still using fax machines and PDFs. And I had a echocardiogram done about a year ago. The only way I got my data back was on a CD-ROM. I don't even own a CD-ROM player anymore. So we have a lot of room. We're still in the early stages and early innings of smartly digitizing healthcare. And for the entrepreneurs listening, a lot of folks try and go back and digitize the old. So I'm going to make a digital fax machine. Well, great. Maybe we don't need fax machines to better communicate and integrate patient-centered care. We can reinvent the model in new ways.
And the other thing you mentioned, we still have the fax machine with the CD-ROM, and part of it also sometimes, maybe me being stereotyping, many of the physicians are not technology savvy. This is what they are trained, and they are comfortable with what they have. And how do you, with all this slew of technology, how do you bring the physician to be part of the innovation?
I think we've all the word, user-centered design and design thinking and certainly workflow. Most of the examples physicians they think health technology, they think Epic EMRs. That is not technology. That's based on 70-year-old 1970s based coding technology with the world's worst Web 0.5 user interface that burns physicians out and clinicians out, and isn't a good example of in some ways, is a hindrance to care. What we want technology to do is get out of the way and make it easier for clinicians. You don't need to be a tech-savvy doctor or tech-savvy. We all now use, let's say, Amazon Alexa or Google Home. You don't need to boot it up. You don't need to go in there and turn on the app. It works just with voice. So that's an example, I think, of smart integrated flow where you don't need to be a technologist to prescribe or use an app. Or we overuse example of Uber. Think about the hassle factor of having to call a cab, wave it down, pay with cash, have some little yellow receipt, all that stuff. Now Uber, which didn't invent any of those technologies, connected the dots to make the workflow easier for both the driver and the cab driver and the rider. So some of that element in thinking could certainly come to healthcare, and I think there's lots of examples of that integrating in and sort of this Uberization of health and medicine. So it's super easy to press a button and get your prescription filled, or for a clinician in their workflow to look at the digital health exhaust from their patient and look at their sleep patterns and inferences and use that in whether it's a virtual visit or inpatient or in person.
So do you think now there's, like you're saying, there's an explosion of digital health solution, and as a physician, probably you'd be like, Gus, how many more data do I need to get from one patient? And, because they're busy already. And do you think eventually there's this emerge of technology, just like Apple Watch, hopefully they can measure the blood pressure, the EKG and everything, instead of covering all your body with all different sensors.
Right. I mean, you want integration, just like you don't want 50 apps for every vital sign or every clinical problem. You don't want 50 different wearables. And in fact, we're going beyond wearables. There's underwearables, companies like Spire, a little tag, you get a health tag, 10 of them and 10 pairs of underwear that seamlessly tracks your data without thinking about it or having to recharge things. We're seeing now, Wi-Fi, Dina Katabi at MIT, using Wi-Fi to pick up vital signs, or modified speakers in the home can even start to pick up behaviors and falls and other sort of digital biomarkers. Cameras now on our laptop or phone can pick up heart rate, respiratory rate, O2 sat, maybe soon blood pressure, maybe even soon hemoglobin, maybe even soon EKG, maybe even soon our neurologic conditions based on eye tracking. So a ton of new data is coming in different forms. And yes, there's almost too much of it. No clinician wants the data. They don't want to look at your raw sleep score or every EKG. They want the synthesis of what does that mean. So I think what we need to move is from exponential data to insights and actionable information, and then narrow the gap between that insight and something that can be used by the clinician or the patient or the home caregiver in a sense, and synthesized. Just like many wearables, I'm wearing a Fitbit and a Whoop and an Apple Watch. They all can measure sleep a bit differently, but they give me a bit of a synthesized score. I get a sleep score from my Fitbit and one from my Whoop, which shows my readiness level. And my Apple Watch, there's several apps that kind of give you an overall readiness score. And so I think, it doesn't matter that these aren't all FDA cleared. I think a lot of the interesting element for a clinician and a patient is what's my change from baseline. If my resting heart rate was 55 and all of a sudden over a month crept up to 70 while I'm sleeping, is something going on cardiovascularly? Could that ping me or my clinician and say, hey, Daniel, you might want to come in and get your other numbers looked at. Something's going on cardiovascularly. So I think as we see platforms like Verily's Baseline doing 10,000 plus volunteers sharing their digital data, their omics and medical records, projects like the NIH's All of Us trial, which you can still join and be a data donor, we're going to have much more, we're not just going to get the data, we're going to understand what it means in context and have much more of a dashboard around our patient. And some people summarize where this is going to head as sort of having a digital twin, just like you can simulate a simulator what might happen to a drug or a flight simulator for a plane. We'll start to simulate taking all the data, your digital exhaust, your genome, your microbiome, your sociome, where do you live and what context, and hopefully use that in smart ways to better predict what's going to be the best wellness path or screening modalities or best way to work up a patient if you have to do a diagnosis, or therapy that can be much more truly precise, personalized, and adaptive. And I think if we all can start to become data donors and start to build those sort of Google Maps or ways for health, we'll better move to an era where when you're a clinician seeing a patient and you have to make a decision about what, let's say, drug to treat, maybe you're going for some 10-year-old clinical trial, double-blind placebo-controlled trial that was very narrow in terms of its, inclusion criteria. Hopefully now you can take all the data from UCSF, like Joel Butte and others are working with, or all the data from Kaiser or Geisinger or NHS, and maybe combine it all together. Like patients like this who have this genomics and these comorbidities might do best on drug A and drug B, and we'll have real-time inferences, just like a Google Map or Google or Waze gives us a real-time traffic pattern and suggestions on how to get to where we want to go.
This podcast is sponsored by Brown Rudnick's Global Life Sciences Group, a team of legal professionals that help life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownrudnick.com. This podcast is also sponsored by Canon Quality Group. Canon Quality Group has been helping medtech startups set up quality management systems for over 10 years. If you're unsure when to get started with quality management in your startup, turn to the experts at canonqualitygroup.com.
So do you think the data eventually will be available for many different people to access? Or you have to, like with UCSF patient data, it's not something that they make it available for commercial. We make it available for our researcher. You think you'll see the transition?
Well, I think it doesn't. Ideally, of course, it's not going to be identified data. There's de-identified data. I think Atul Butte and others at UCSF recently published that, based on racial differences, the normal values for everything from hemoglobin to vitamin D to potassium levels, they're not the norm for everybody. And you can present that it was taken from lots of de-identified patient data. That would hopefully, if I see a patient in the future, virtually otherwise, I'm going to put that in context with what's normal for that, at least that rough ethnic group, which might be useful. So I think, there's a lot of concern about privacy. Obviously, our digital exhaust can be collected in all sorts of ways. And, Facebook and Amazon and Google all have different forms of information, which can glean our health-related elements as well. So I think we need to be smart about enabling folks to share data when they would like to, still make sure it can be kept safe and anonymized, but not be a hindrance. I think HIPAA, well-meaning of a regulation, was done pre-digital. Now it's being used as a hammer and a disincentive and a bit of a club, and is scaring people. Oh, you'll be HIPAA non-compliant. We need to reinvent HIPAA. Just like the pandemic has helped catalyze, relax some HIPAA laws. We can now have a physician-patient visit on Zoom or Skype or otherwise, and it's being paid for as well. We need to rethink our regulations in this sort of new exponential digital age as well.
Right. As you can see, like different country has more relaxed if on their patient data.
Yeah, you got the GDPR folks out of Europe and Germany. They're much more data privacy centric, and then you got places in Asia where privacy is completely dead. There's got to be some middle ground. People should be able to opt in and opt out. I think if you opt in and you're a data donor, you might get a better information back. Like, imagine if Google doesn't ask us if we want to donate to Google Maps or Waze when we drive. You can opt out somehow, but it's the default is that you're donating your driving speed and location. In exchange, you're getting something back. Imagine, if we have smart incentives when you donate data in a way anonymized safely, that it helps build a better map and we're all in it together. And I think the pandemic has been, again, a bit of a lens to realize that, we don't live in isolated elements. If someone's not wearing a mask or not being tested or vaccinated, that impacts all of us downstream, and there's lots of butterfly effects.
Right.
What happens in spring break in Daytona Beach can impact, the pandemic in California 2 weeks later.
Yeah. No, this is, I think, being in a healthcare the next 5-10 years will be really interesting. I think there's a lot of exciting things that people are working on. Before I want to change it a bit, just different subject about your Singularity University and Exponential, your work in that space. Can you tell us more about that? Your work in Singularity University, what is it? Like, how people work with you guys?
Well, Singularity University started about 12 years ago as the idea that, to really catalyze and address grand challenges in the world, from healthcare to poverty to education to environment, you need to bring folks together from different realms, different technology realms, and to understand where is the puck going in terms of AI, robotics, 3D printing, nanochecks, synthetic biology, blockchain, nanotech. All these technologies often are moving exponentially. Singularity was co-founded by Ray Kurzweil, who wrote the book The Singularity is Near, invented speech-to-text and other elements, and Peter Diamandis, a Harvard MIT trained physician who started the XPrize as well. So I've been the chair of medicine for SU, which is not a traditional university. But out of that, what was really interesting is almost everybody's interested in health, their own health, or their family members, or their community, or the planet. And, a lot of healthcare and medical education is very siloed. I'm trained as an oncologist and bone marrow transplanter. I'll go to ASH and ASCO, the big meetings around oncology, hematology. The cardiologists go to cardiology meetings. There's digital health meetings and pharma meetings. But very rare do you mix people up from different fields to cross-fertilize. So I started a program 10 years ago called Exponential Medicine, with the idea that people need to understand the pace of exponentials, like the falling rate of sequencing a genome dropped to twice the rate of Moore's law, to what's happening in AI, machine learning, and application, and Internet of Medical Things, all moving sometimes exponentially. And so Exponential Medicine has been an amazing sort of platform and playground for folks from at least our last in-person meeting in 2019. We had, I think, 45 countries, 500 different organizations, patients, payers, physicians, investors, the whole gamut, mixing it up and going, wow, where are things headed? Where are examples of things that have worked in other places? So lessons from Tel Aviv or rural Africa can leapfrog back to, let's say, the U.S. And so basically the idea around Singularity and Exponential Medicine is to bring folks together from different realms to understand the pace of where things are heading across different fields, how they're converging, and how we use that convergence in the case of healthcare to create entire new fields: robotic surgery, digiceuticals, AR and VR for medical education and therapy. All those are at the interface of technology and medicine, and many of those fields, in a sense, didn't even exist, when I was a Stanford medical student 20 years ago.
And how, for somebody who are entrepreneurs or innovators, how do they engage with, that organization?
Check out exponentialmedicine.com. Sign up for the newsletter, and you'll get every couple of weeks an update of where's technology taking healthcare. Follow me on Twitter at Daniel_Kraft or at Exponential Med. That's one place to engage, and we're going to evolve the Exponential Medicine platform to be much something beyond a annual conference, but to be one where we have a bit of a platform for real-time innovation throughout the year, just like we now live virtually. I think the old model of just meeting once a year, whether it's HIMSS or JP Morgan or other, how do you keep those dots connected, and how do you help folks collaborate and meet and solve problems and learn from each other in new ways? And I think COVID's been a catalyst for that as well. So check out exponentialmedicine.com. Especially our videos page has some amazing lessons from thought leaders, from John Halamka, who now runs platforms at Mayo, to we had the CEO of Moderna 5 or 6 years ago. You'll see things early, and that'll give the entrepreneurs and the health system folks and clinicians an idea of what might be possible. Because when you're solving a problem as a clinician or as an entrepreneur today, don't think about what's just available in 2021.
Right.
Think where, the iPhone 15 will be, which will probably be an AR headset coming out of Apple. Think about where Moore's law will take, the power of computing. Think about the price of a sequence might be, or the ability to create synthetic biology mediated therapy. Think where AR and VR will go. I mean, look what's happened with, 10 years ago, we took a $2 million lab at Stanford. Now you have that integrated in Oculus Quest for $300. And AR and VR are a good example of exponentials coming together for everything from medical education to therapy to collaboration on the virtual front. So pay attention to where things are going. Don't build with a 2021 lens. There's a quote from Bill Gates that I like. We tend to overestimate what will happen in a year and underestimate what will happen in a decade. And I think, while the last decade's been pretty amazing, the next 10 years will make the last decade look pretty slow, particularly in healthcare. We can better connect the dots, align incentives, collaborate, and get out of our sort of siloed, sometimes city by city and state by state way of doing, very kludgy and often inefficient sick care.
Yeah, thank you for sharing that. I think you're right. Is especially when you're innovators, don't think about what 2021 because it takes a while to develop what you're doing, and then by the time you are ready for market, it's back for 3 years down the road already. But the other things that I was thinking about the current dynamic of the population, there will be a lot more elder care. What do you think? What that elder care is going to look like in the next 10 years? There's population, of course, it's nice to have all the young people can support all the elder people, but I think that's not happening as fast as the growth of the elder.
Right. We see in certain markets like Japan where there's a huge disparity and the aging population is outpacing in terms of size. And we have this age wave coming. My friend...
China is going that direction too.
Yeah, my friend Ken Dykewald has this whole platform called Age Wave, which looks at those things, and there's tremendous opportunity. Now, I wouldn't call it like, I could almost call it, senior care. Aging is changing. 90 might become the new 60. There's a lot of obviously investment looking at quote unquote longevity, not just your wrinkles, but actually maybe stop and reverse the aging clock. And it may well be that folks who are staying healthy in their 20s, 30s, and 40s may, in many cases, live to 100 plus. So what's that going to look like at a societal level? And none of us really want to live or end up our last, few years in a quote unquote nursing home. So think about aging in place, all the new technologies that can enable an older person to be independent, whether it's help with cognition and their smart hearing aid also helps give them cues to who they're talking to and where they are if they might have early cognitive issues. It's using robotics in the home, whether it's your Roomba to clean the floor or your Amazon Alexa to help detect a fall or communicate with your clinician. It's cameras that can detect behaviors and keep folks monitored. Definitely some privacy issues. A huge opportunity to, I think about aging technologies as well, because, the 50 and 60 year olds now, they're super tech savvy. In 20, 30 years, they'll be the seniors. There's, again, a huge opportunity in that space. Part of that's remote patient monitoring. I mean, that's exploded in COVID. You don't need to bring someone in for their annual checkup. You can tell from their wearable or their non-wearable how they're doing and intervene early or tweak their behaviors. We're looking at precision nutrition, how to optimize someone's health span based on nutrition, which is not a fad diet. It might be based on someone's metabolomics and microbiome and base genome. So lots of ways we can extend, I think, a health span, not just lifespan, because I don't think many people listening want to be 120 and feel 120. Huge opportunity space.
Maybe 20 years from now, 120 is okay to feel like 120 because that 120 feels more like a 50 today.
Right, we'll be wearing our exoskeleton. We'll have our AR contact lenses. We'll have drones that deliver our meals and our meds immediately. We'll have our and it will be more independent. You could travel virtually, or you'll travel with Uber drone across the country, or maybe a SpaceX ship will take you across the planet in 20 minutes. So a lot's going to change in certainly 50 years. And I think we have definitely ethics and other regulatory and policy things to think about. Just like AI can be used for good or for bad, or 3D printing can be used to print a gun or a pill or a medical device. All these things have pluses and minuses, including the challenges of a longer lived population.
Yeah, no, I think it's an exciting time to live right now, and it will be interesting to see what 20 years from now, what kind of technology we'll have for us.
Well, tremendous opportunity, particularly for entrepreneurs, right, to identify a problem and solve it. When I was a Stanford fellow, I was part of the first year of Stanford Biodesign. It's all about finding an unmet need, understanding it in context, not just designing something and going, I'm going to apply it into this clinical setting. But now, if you're a college, a Berkeley student in the dorm, you've got the power of what used to require $100 million lab. You can now do even CRISPR in your basement. You can 3D print a prototype. You can outsource coding and leverage AWS and not require $10 million of infrastructure to innovate. And now there are new platforms for virtualized clinical trials. You can design an app and deploy it immediately in some cases. Tons of opportunity for the entrepreneurs out there to solve some of the pain points in healthcare. My concern is often these are point solutions. We need to integrate them into holistic elements, like I mentioned with digital.health, and collaborate better. I'm chairing the XPrize Pandemic Alliance Task Force. Particularly in the early stages of the pandemic, everyone was trying to 3D print PPE or making their own version of a ventilator. Sometimes It's not about having 100 versions, but how do you bring together folks who might even be competitors to collaborate and build a better PPE system or clinical trials network, or leverage better testing that could be applied for COVID or for other diseases downstream.
Mm-hmm. Yeah, that's one of the good thing, I think, about the silver lining with the pandemic. I feel like people are more collaborative, trying to solve this problem, and I think that's the good side. And it's amazing when you bring people together, amazing thing can come out from it.
But on the dark side, we've seen certain forces try and keep people apart or to divest things. We've had over 500,000 Americans die from COVID, and I would argue that a lot of that is at the hands of our prior administration, who completely botched almost every element of the response, from testing to mask mandates to splitting folks. We still see, there's an infodemic on top of the pandemic, and we still see many folks who are on, let's say, the left side of the equation refusing to get vaccinated or having vaccine hesitancy based on messaging from folks. So, it's unearthed a lot of other, not just disparities, but disparities in mindset. And I think one thing we can learn, we need to learn to work together. And somebody not wearing a mask, it's not the same thing as having the right to carry a gun. It affects everybody. So I think we have some healing and coming together post this as well. And that takes leadership. And I think, as we've seen with our new administration, we've sped up a lot of elements that if implemented, a year ago would have saved, eons of life. We have the number one healthcare system in the world, arguably, or some measure, U.S. healthcare system, but we're, top of the list of, deaths per capita from COVID. So it's really pretty inexcusable, and we should all do better next time. Because in many ways, this has been, as my friend Larry Brilliant says, a practice pandemic. And the next pandemic could be a disease with a higher infectivity rate and much higher mortality. And we need to take the lessons from this one and prevent it from happening. But if we do have one, respond in much smarter and faster ways. Yeah,
that I hope we learn our lesson. That's important to get ready for the next one, which is, I hope I don't have to live through that. But thank you so much for your time. It's been always exciting to hear your thought and insight, and it's been fun to hear from you.
Yeah, thanks for having me.
Great. Thank you.
Thank you for listening to another episode of the Health Technology Podcast. We want to thank our executive producer, Herminio Neto, our content writer, Kelly Muscat, and our podcast engineer, Andrew Rojek. If you enjoyed this podcast, be sure to subscribe and leave a review. The Health Technology Podcast is available on all major platforms.